you just have to remember, if you have a hammer you're comfortable with, it probably has positive and negative features. The other thing is, I remember rounding in Philadelphia with the neurosurgeons and having grand rounds with them together. They would say things like, you don't really need any equipment. You can do the sensory exam with just touch, you can draw numbers, you can do all that, and you can just use your, one finger on a tendon to see whether there's a response. And sometimes you have to do that. But basically, if you're going to do a neuro exam, you want to know what you're doing. It's kind of like if you ever played baseball. You have to, even if you hit it out of the park, you've got to touch first base, second base, third base, and then home plate, or it doesn't count. If you're going to do the cranial nerve exam, you should do them all. You can't say WNL. That means we never looked. You see it all the time on medicine reports, WNL. Neuro exam, WNL? What did they do? The guy was talking to me, he was conscious. Is that good enough for them? We want to know what you did, because tomorrow or the next day or even in a couple hours, if the pupils are now asymmetric, we want to know if that's old or new. So you really have to document it, and I'm having Crystal bring over a form that I usually use so you know which bases to touch. Okay, so I don't have any more to say in introduction, so what I'm going to do is I'm going to show you how I'm going to do this. So, do you really have to do the first cranial nerve? No, not always, but you should probably know how to do it. So I'm going to pick somebody, I'm going to ask you to close your eyes, and I'm going to say, all right, you tell me when you smell something, but don't open your eyes, and then, smell anything yet?
Mm-hmm.
What does it smell like?
An orange.
Okay, so now she saw an orange over there, but it could have been. So she's no dummy. But then I've done that, and I don't do one side or the other. I mean, there are possibilities that one side may be affected by a meningioma in the olfactory groove on one side. It may get that second cranial nerve on the same side eventually, and you may have swelling, and there's a name for that syndrome. Anyway, let's go ahead to the second cranial nerve. How do you check that? What's most important? Dr. Hofer, how would you, let's say you're seeing a patient in the ICU, you got a lot of other patients to see.
Most important is light.
Yeah, the light response. Does somebody have a pen light that's good and bright?
Yeah.
Okay, let me show you. I'm going to move around, so, okay. Okay, that's very good. So it's, I don't want to laser beam. I'm going to assume you're okay. So what I do is I go like this, and I make sure they're the same. You have a card like this that tells you how many millimeters. And we had a lady over at the VA, okay, so it's 3.5 millimeters on each side. Then what I do is I shade the eye, and I come into one of them, and then I see with the bright light, do they both respond the same way? And on the slides I'm going to show you, you can go from one side to the other, and that's a relative comparison. So there's a control on one side. If you have, let's say, a second cranial nerve on this side, when you shine a light, it seems like a dimmer light, so it's not going to constrict. When you go to the other side, it's going to constrict more, and you can see a difference. We'll talk about that. Those are the important things to do. Hey, thank you so much. The next thing I'm going to do is I'm just going to ask somebody, can you, Dan, can you cover one eye? I want you to hold this up wherever you want. I'm going to point at something. Tell me if they're X's or O's.
O-O-X.
Okay, I'll do the same thing on the other side. I'll let him use his lenses. I don't care, and then I know he's got Jaeger 1+ vision, and I can put this away. So how do I do visual fields? Let me just show you. Cameraman, maybe I'm going to ask you sometime, but can I have a volunteer to come up?
Kristen.
Yes, yeah. You want to volunteer? Oh, how about if we have you come up? So I'm picking on, all right, so what I do is let's just do a confrontation. So close one eye. Okay, and I'm going to close and then what I'm going to do is I'm going to find where try to get halfway between and say, how many fingers wiggle? Okay, I'm done then. How about now? No? Do the same thing on the other side. I'm looking at the outside. How have I checked the macular vision? With this guy. And you don't have to go into any more than that. Another way to do this, the other day we had a guy in the ICU over at the VA that Dr. Gupta and I worked on together, and I just went like that to the guy, and he blinked, and there was nothing, I wasn't blowing air on him. So there's other ways of doing this. And then there are people that claim that they're blind, and you just get a mirror, and you put it in front of them, and they'll look at themselves, you know, what's more important than myself, and they'll follow. And you can do, you know, visual fields that way as well. And they'll look at you. If they look at you, then they can see you. There's all sorts of things you can infer. Thank you very much. You passed. You guys are conscious. Okay. Any other questions? So visual fields, and then fundoscopic, you've got to learn how to do that. My trick is, if you get a light, an ophthalmoscope, what you want to do is make it really dim. And you want, by the way, did we circulate those?
It's beige.
Oh, why don't we circulate them? This is, if I can ask you to do that. This is what I use, just so you have a checklist, and I can do it in my sleep and when the patient's asleep practically now, because I've done it so many times. I think we have enough. I asked for about 20. Okay, so we're going to practice these things, and there's lots of different ways of doing it. I'm going to go to extraocular movements. Dr. Hofer, could we check you, please? Okay, so we're going to make sure you guys are okay. They said make sure that they have normal neuro exams while you're at it. Okay, so what I'm going to do is there's a couple ways of measuring eye movements. And first of all, if a patient has a weak right eye that cannot abduct, what they do is they turn their head that way, so they're moving their head in the direction that the weak eye cannot move. Okay, because if I'm looking like this, I never have to abduct my eye. If I'm looking over this way, then this eye is going to stay here and the other one's going to go over. See where I'm going with that? So another way to check is, I'm going to ask you, hold your head still, look at this finger, and now go from one to the other. And which eye kind of movements am I measuring there? Saccades. That's like a French for a jerk on the rein. In other words, it's really quick. You can measure it in terms of how many degrees per second you can move. The other way of doing it is following or pursuit movement. So look at this finger, and this is where you act like the Pope, and you go over here and you make the cross. And I see he moves his eyes very slowly and very well. And I just want to show you something. I don't know if you want to zoom in on his face. I'm going to have you pretend like you're looking at my finger here, only I'm not going to have it up there. I want you to go from your left all the way to your right really slowly. What do you guys see?
Saccades.
Saccades. He's making jerks, because you cannot do that unless you're following a floater. Okay? So, and you can probably do that. I mean, I think of these things all the time. Well, what are the exceptions? Any questions so far? Now, I know a lot of this is old hat to you guys, but it's good to review it and to ask each other, are there any other things you find helpful? You can do head maneuvers. I know Dr. Kadar does the quick eye jerk, or turning of the head and so on. I'm just going to move on to 5 and 7 and keep going. So
Optokinetic strip is
optokinetic strip is also very useful, and sometimes you can use a tie that's got a pattern, or you could walk sideways one way or the other, and we'll have people, because you got a striped shirt on, is that going to be Air Force kind of material or what? Absolutely, okay. So if you happen to have, if you happen to have a striped tie on, but you guys don't wear ties anymore, you're more relaxed than we were. Okay, so I'm just going to show you. So if he smiles voluntarily, I take it. You take what they give you. He's got a very symmetric smile. Now I want you to go like this and tighten up these muscles. The platysma is a very important 7th nerve muscle. Okay, shut your eyes super, super tight. Don't let me pry them open. Okay, good. So I think 7 is okay, and there's other ways of doing this. We can talk about it. I can show you. how to do a corneal reflex, but usually we skip it. We're going to get through with the 12 nerves, and then we're going to practice here in a minute. So this shouldn't take more than about a couple minutes more. So take off your glasses. I'm just going to show you. Close your eyes, not too tightly. If I would go, I'm just going to take something like this. Keep your eyes closed. He's going to say, what are you doing? Okay, so let's have him turn this way, okay, so you guys can kind of see. I'm just going to touch his eyelashes. And this is not totally kosher, but if I do that in a patient that won't let me touch the cornea, he feels the stimulus with the 5th nerve and he blinks with the 7th nerve, okay? So that's another way to do that. I'm not going to show you how to do taste. Close your eyes. And I'm going to say, okay, which side do you hear a noise on?
Left. Right. Oh.
I'm done. I can't hear this. He can. He's closer. I'm done with that. Now you can do Weber and Rene test. There's how you do these. Which is louder, behind or in front? Or is it a toss-up? Let's find your, do you have a mastoid? Okay, let's see. Hear that, and now this is that one. In front should be louder. Okay.
Louder in front.
Okay, and then same thing here, and I want to do it, same thing. Okay. Another thing you can do, and you guys can try this on each other, I'm going to do this right here, and if I go like this, do you hear it more on one side?
Right.
Okay. So when I do this, the right answer is, oh, I hear it on the left side because that's bone conduction, right? Mm-hmm. Or if he's got earwax in there, fine. So for okay, we're almost done here. Turn your head, let's see, open your mouth wide, and I'm going to look in and I'm going to say ah.
Ah.
Okay, if I had a tongue blade, I could go back there and touch the back of his throat, and my mother was so sensitive. When the doctor did it on me as a little boy, she would gag. So, there's all sorts of reasons why you may gag or might not. It's okay to not gag on both sides, but if you have a very strong one on one side and none on the other, there's got to be a reason for it. And you look at the raphe, not the uvula, because things may not be there. I mean, you may have a bifid uvula, all sorts of crazy things. And it should go up straight. And we can have a show on this in just a minute as well. Okay, for 11, I usually do this with motor. Turn your head this way, real hard, and don't let me turn back. I tell them hold it there, and then I can see the muscle. I can feel the muscle. I like to use all my senses. And then I do the same thing on this side. Push hard as you can over this way. And so I get them in a position, because if you don't explain to them, hold it there, when you do this, they're going to wonder, do you want me to go the other way or what? So I just say, hold it there, don't let me move it. And then it's a mano thing, and see who's stronger here, whatever works. Stick your tongue out straight. Okay, he does a good job on that. He doesn't have atrophy. I'm done, I think, with cranial nerves. Do you want me to show the slides, or do you want to just go to practice?
We can go to practice, so we can go through some tips before. So one of the questions that is often
Thank you so
asked
much. You're also
from the residents is which of the cranial nerves you can perform on an unconscious patient in ICU. So let's move the camera around, take a poll from the senior residents.
So second for light reflex.
Can you do one?
Excuse me?
Can you do one on an unconscious patient?
I don't know. Probably not.
Oh, if they're malingering, you can give them a really, really bad smell, putrid smell, and go like that.
You have to be a little careful, because there are some things that are 5th nerve irritants, like ammonia, that kind of thing. But if they don't like the smell of an orange, or if they react to it, then you know they're not in coma.
So second nerve, what can you do in second nerve?
So light reflex.
Whatever.
You can do visual threat, but in reality, if their eyes are spontaneously closed and you have to force their eyes open, then that usually doesn't work.
Yeah, but if they're resisting eye opening, that's a sign that they're conscious. An unconscious patient will not resist eye opening. So actually trying to force eye opening is a way to check the 7th nerve, because if they're fighting it back, they have a normal strength to close their eyes if they're resisting eye opening. But if the eyes are open or if you easily open it, then yes, you can do thread reflexes. Be very careful that if you bring your fingers close enough, which you should, and it touches the hair of eyelid, they can have a blink from the touching of the eyelid here. And actually, if they are closed and you just touch their eyelid, they can blink from that. You can get a blink reflex just from touching the hair on the eyelid. Good. What else? After 2 and 7. So other way to check 7 will be the nasal tickle. They can get a facial response by irritating those. Gag reflex, they may have a facial response on the 7th nerve. What else?
3, 4, 6 with oculocephalic maneuver.
Perfect. So 3, 4, 6 is oculocephalic. You can move their head, and if the eyes are moving around, then 3, 4, 6 lower motor neurons are intact. It doesn't say anything about upper motor, but they have to have a functioning nerve and a functioning muscle for the eyes to move, even if it's just a reflex, if it's not a reflex.
Okay, what do you have to
Full
worry
calorics.
about, excuse me, what do you have to worry about before you start moving the patient's head? Yeah, you want to make sure that they don't have a C2 fracture or something like that. You're going to pit them in the process, especially in an unconscious patient.
Okay, what else? How about 5?
Corneal reflex or the nasal tickle.
Right, you can do nasal tickle colon reflex. How about 6th? That was part of 3, 4, 7, and 8.
Cold calorics.
You can do cold calorics, so you can take the vestibular part of the 8th nerve.
So what do you have to do before you do cold caloric?
Look in the ear, make sure.
Make sure that you have a good eardrum and you don't have a perforation, and you don't want 3 little bones to come floating out as you're doing the cold calorics.
That's not gonna happen, but you can cause
That's not going to
infection.
happen. Yeah, you can cause infection, and sometimes you see.
For the first, you'll have to say it's not gonna happen. They may not
Yeah.
get a joke.
Yes, okay, yes, it's
The bones
not
will
going to
come out.
really happen, but you don't want to put things in the middle ear.
Okay, and then of course we can do the gag. You can see gag is a reflex, so that's 9th and 10th. And the 11th is the one that will be hard to do, but unless if the patient is posturing or responsive to painful stimuli, then you can even check the 11 by the head turning or pain on one side, then they withdraw from it and turn away from it.
Especially, with the nasal tickle, they'll move their head away from it as well. And like I say, if they're moving and you see their head going from side to side, then you have that information. That's what we did with our patient in the ICU. We just watched him for a while and saw everything was symmetric, and then usually I start with the less invasive things. So I'll do the reflexes, nobody's going to be hurt by that. You don't have to hurt somebody with the Babinski. I remember we just touched his feet and they withdrew. So then you get more and more invasive, and again, you don't have to do it first cranial nerve to the 12th, and then do the motor, and then do the sensory, and then do the reflexes. You do it in whatever way is best for the situation.
Good. So we're not talking about pathologies here because we have a separate lecture on cranial nerves, actually 2-hour lecture, where we'll talk about the anatomy of the nerves and also pathologies like what will cause increase in smell, what will cause a loss of smell, what's the differential for that, and things like that. And there is, of course, in terms of smell, there is one is at what level you can detect the smell sensitivity, but then there is the identity of smell. Can you tell if it's a smell and then what type of a smell it is? And one may be lost without the other. One is cortical feature and one is a peripheral feature. But we'll talk about it separately. I think we can divide in 4 groups. I'm going to invite
I
the
think
Chief
so.
President,
So-
Kyle, to tell us about the 4 groups and to do the breakout session.
Okay, let me just sum up a little bit here. So the answer to the question, what cranial nerves cannot you do in a patient in coma? First cranial nerve, you're going to have a hard time. If they're really in coma, they're unresponsive and unarousable. But there's all the gradations between awake state and whether you've been on call, whether you're paying attention to this, whether you're thinking of something else, from one to the other. But you should be able to do almost everything. Maybe 11, but 11 you can sometimes do. I remember one uncooperative patient that had mental status problems. I think he was a problem at birth, and I couldn't get him to do anything. So I did a gag response, and I'm telling you, he just went like that. He was so sensitive to the gag response that he stuck his tongue out for me in the middle. He opened his mouth, I could see his palate go up. He made a noise, he phonated, and he extended his arms and his legs, and he shut his eyes tight. I said, holy cow, that was worth doing. And it's not harming somebody just to touch the back of the palate. You know, sometimes if you can't, let's say, open up the jaw, there could be trismus, there could be some dislocation, but you don't want to force it. And sometimes, you know, you catch them yawning and you look in there, and then you can do it. So you take what they give you and just be prepared. So, okay, I'll yield to Kyle for breaking
All
us
right,
into
Kyle,
groups.
break out